Now that we transition to celiac disease, which is an autoimmune condition triggered by gluten exposure in genetically susceptible persons, prevalence is relatively low in the population in the United States, and gluten exposure will activate an immune response that damages our villi of the small intestine, which leads to nutrient malabsorption and systemic effects. It's essential to remember that celiac is not a food sensitivity, it is an autoimmune enteropathy. Almost all patients that have celiac disease express certain HLA types, specifically DQ2 or DQ8. These molecules present gluten peptides to T cells, enabling the autoimmune reaction. Concordance rates are much higher among monozygotic twins and first-degree relatives. However, not everyone with DQ2 or 8 develops celiac. Genetics will increase the susceptibility, but gluten exposure and immune activation determine the disease expression. This is showing how DQ2 and 8 molecules present gluten fragments, and it shows both cis and trans inheritance patterns, which reinforces that genetic testing can rule out celiac disease or decrease clinical susceptibility. Neither DQ2 nor DQ8 are present. It would be very unlikely that celiac disease would occur. There are some populations, though, that have significantly higher prevalence. Patients with dermatitis herpetiformis, autoimmune thyroid diseases, type 1 diabetes, Down syndrome, Turner syndrome, and first-degree relatives with celiac disease all have an increased risk. Many patients can present not with GI symptoms, but rather unexplained anemia, early osteoporosis, neuropathy, or even infertility. So a high index of suspicion is key. Celiac disease, as seen here, has a broad range of GI and extra-intestinal symptoms. Classic gut symptoms are listed on the slide, like chronic diarrhea, gas, abdominal pain, weight loss, etc. And outside of the gut symptoms, I mentioned a few, include neurologic dysfunction, persistent fatigue, even early osteoporosis or osteopenia. Patients are often misdiagnosed first with IBS, and so the key clinical pattern you're looking for is malabsorption plus a systemic manifestation. This slide is leaning into more who should be screened, and screening should be done in symptomatic patients at high risk. This could be people with autoimmune liver disease, premature osteoporosis, unexplained transaminase elevation, liver enzyme elevation, or unexplained iron deficiency anemia. And these patients should all undergo serologic testing prior to referral. So again, looking at some screening guidelines, consider testing when symptoms could be secondary to celiac disease, like short stature in children, Sjogren's, Turner syndrome, neuropathies, migraines, etc. If a patient has a first-degree relative with celiac, it's important to test them. Importantly, if a patient is already avoiding gluten, their antibodies could normalize. So they must be eating gluten for the test to be fully accurate, which is going to present us with a problem. Serology is often our first line diagnostic approach for celiac disease, and the most sensitive and specific test is IgA anti-tissue transglutaminase, or TTG IgA. It has a greater than 95% sensitivity and specificity rate. IgA endomysial antibody is also highly accurate, although it's more expensive and kind of operator dependent. It's an important point to note, though, for accurate testing, patients have to be eating gluten actively. Also, total serum IgA should be checked because selective IgA deficiency, more common in celiac patients, will cause a false negative. Because if IgA deficiency is present, we then switch to using IgG-based testing instead. Historically, you must have had a small bowel biopsy to confirm the diagnosis, but if serology is strongly positive and symptoms improve with a gluten-free diet, we do not need to subject patients to a biopsy. It can still be recommended, though, if serology is negative but clinical suspicion's high, if symptoms persist despite removing gluten, or if the diagnosis is atypical or uncertain. When you do this biopsy, I mean, you won't perform it, but you could order it. Multiple biopsies are taken because villus atrophy can be patchy. The hallmark findings of a biopsy would be crypt hyperplasia, villus blunting, and increased intraepithelial lymphocytes. And this is showing some of the signs that you could see before we have this beautiful villi here with our nice microvilli. And then you can see they've been blunted, almost like they've been shaved off. You're seeing kind of these crypts present here. This is giving us a decision-making algorithm. There's plenty of them out there for integrating and interpreting serology and biopsy. So you can see if IgA-TTG is positive, the diagnosis is likely. You could do biopsy, be done, or a patient could begin a gluten-free diet with monitoring. If the test is negative, but suspicion remains high, you would consider IgA deficiency and follow up with IgG-based testing, HLA typing, or biopsy. And the key takeaway is serology plus clinical correlation drives the diagnosis, as celiac disease is never diagnosed on elimination diets alone. It is going to be different than our food sensitivity tests. Now, once treated with a gluten-free diet, antibody levels are monitored to assess compliance and improvement. IgA TTG levels should drop and often normalize within 3 to 12 months of a gluten-free diet, and symptom improvement should follow. Repeat biopsy is not routinely needed unless symptoms fail to resolve or new issues develop. Persistent symptoms while on a gluten-free diet would warrant evaluation for hidden gluten exposure or other GI pathologies.